Good morning, all of you. Yeah, it's good to see such a big audience come. And now, what's the problem with the technology? It's making noise. You know, I always tell people in Uganda, for us, we have inbuilt woofer, so we don't need all this kind of technology. You just talk, the message goes out. So the people who are controlling the technology, they have to give direction. You can see all this wiring. So I don't know what it is all about, but they know better. That's the foundation, Kigezi Healthcare Foundation. You can see that is English. See, you have to come up with a name that is convenient for everybody. So if we put a name in a local dialect, then reading it becomes a very big problem. Actually, I have one of the simplest names. Some of the names from West Africa, you bite your tongue while pronouncing. So now, Kigezi Healthcare Foundation is okay for people outside Uganda, for the educated people, but then we are working with the local communities. They are not going to pronounce all this English word, so you have to come up with something that fits them. So KIHEFO is the popular name for Kigezi Healthcare Foundation. KI is for Kigezi, HE is for healthcare. So when you come to Uganda and you say you are looking for Kigezi Healthcare Foundation, everybody will look at you and like, what are you looking for? No? Then if you say you are looking for KIHEFO, then everybody, oh, we know. So that is it. Then if you say you are looking for Dr. Geoffrey, say, who is that American doctor? Yeah? Then say you are looking for Dr. Anguyo, then everybody, oh, we know that one. So it's just to bring to you in the context, you know. Yeah. When I'm here, everybody calls me. Actually, I only got to know very well I'm Geoffrey when I started traveling, because in Uganda, that's not how much it is. They use the local name. Just wanted to bring you a brief context where Uganda is. You know, some people think Africa is one country, you know, so there are very many countries in Africa. And whenever I've been traveling, actually, I talk to political science class, I talk to economics class, because there are so many things integrated. One thing I've always said, the British, you know, this American war, it's good you kicked out the British early. So when you kicked them, then they went back and mobilized all the Europeans to mess up Africa. So we are not supposed to have all these countries. We are supposed to be having, it's like United States. So if you didn't kick them out, then Illinois will be a country, you know, all these states will be different countries. So you can see the advantage of being together. So now Africa is also trying to slowly come back together. There is Southern African bloc, Western African bloc, and Eastern African bloc. You see, we work in blocks so that these blocks eventually come together. Now, I give you a typical example of East Africa. In the last 10, 15 years, there's now free movement of people in East Africa. So we don't need passports to go to all these East African countries. There's Kenya, Tanzania, Uganda, Rwanda, and Burundi. So all these 5 countries, we don't need passports. You know, you just cross over. You only need your national ID. If you have your vehicle, you just need the official documents of the vehicle just to make sure it is not being stolen. So there's free movement of people. People work, you know, you work in any of these countries of your choice. You can settle in any of these countries, just like you can move in any of these states in the US. So that is how things are coming up. I think some of you who are in the center, I was told the pointer only works in the center. So our capital is around here, and then the region where we operate is around here. Then I was born around up there. So this, if you travel from here to here, it's 8 to 10 hours. You see, in Africa, everything is one city, one airport, one this. So you can see that's what it means being a developing country. So if you come through our airport, 8 to 10 hours. If you come through Rwanda airport, 2 hours. So we always tell people, make a choice, whether you want to travel 10 hours or 2 hours. Now 95% of our visitors actually pass through Rwanda because nobody wants to travel 10 hours. But they still also want to go and see the capital, you know, how crazy a capital can be. So it is all part of learning process. That is our national flag. So, you know, everywhere Americans go, they take their flag first. So we also try to emulate what you people do. Coming to the gist of the matter, it's like Mary clearly introduced, I was born in a very, very poor family. Now, poverty, there's world definition of poverty. And poverty line actually is $2. But you see, that is $2 per person. Now, in Uganda and most of African countries, we are talking of $2 per family. And some of the families are 10, 15 people. I was just in Montana and we were discussing with some people. I say, you know, for them, they are looking at very poor people earning $15,000 a year. And I say, even a doctor can't earn that in Uganda. You see how we define poverty. And then in Uganda, those living on less than $1, it's below poverty. Now, those living on less than $2 are poor. Those are families, not people. You see, that's where you have to see the difference. Then I was born in a family living on less than $1. Then one will say, how did you then become a doctor coming here in Chicago? You see, so those are all questions running in your mind. Going through the war, like she said, I was recruited as a child soldier, you know, fighting, and then going into the refugee camp. Then 3 years we were out of school. When I came back, I started growing pineapples. Now, growing pineapples, I was able to pay my school fees through high school. Then I was able to get government scholarship to go to medical school. I worked in government hospital for 5 years. Usually, if you get a government scholarship, those days you will work for 3 years, then you can do any other thing. I worked for 5 years. But then, poverty, I grew up in. You can't give me any lecture about poverty because it is part of my gene. It is part of my DNA, you know. So then working in a public hospital for the 5 years. And then during our training, our professors will tell us, because that's when the country was just recovering, a lot of wars, all the infrastructure, human resources. We had very few committed professors. And they will tell you, prepare for a lot of hardship when you are going to get out. And even when we are rotating, especially, I give you a typical example of OBGY. When you are rotating in OBGY, maternity ward, some of you who are medical, you know there are cases where a woman has to be admitted. You know this is a woman of high risk. She has to be admitted and operate. You work on her elective. See, you work on her before she gets complications. We say elective. Now, all these women, because of lack of resources, and that was part of our learning process, because of lack of resources, a woman cannot be worked on until when you become an emergency in the hospital. Can you imagine? So those are the challenges. You know this one is going to have obstructed labor. You are supposed to operate her before she goes in labor, when she's due. But because every time you are having emergencies, you can't take her to theater until she becomes emergency. When she has been on the ward for 2 weeks, 3 weeks, those are the things we are looking at when we were studying. Then when I came out to work, the 5 years, part of the 5 years, I was running a very huge hospital alone. You know, population of like over 2 million. At one time, there was that big shortage. Now you are one. Our training is clinical medicine and surgery. Surgery, general surgery. So you do all these C-sections, amputations, you know, laparotomies. Now you find if you are alone in the hospital, and then you find one anesthetist, and many times if this person is sick, what do? You can't look at people dying. You are giving anesthesia, you are the doctor. You give anesthesia, you stabilize the patient. Then the assistant, if you are a surgeon, your assistant is supposed to be another doctor. Your assistant is a nurse. The nurses have their role to play. Then you use short-acting anesthesia. Then when you stabilize the patient, you rush to scrub. You get sterile. Then you get like 20 mils of ketamine. Put another nurse there. You see? So you have to work very fast. Then when you see the patient is moving a bit, you say, add 5 mils. You have to save very many lives. So you have to be creative. If you are not creative, you just see people die. If you don't make quick decisions and effective decisions. Then, of course, going through these things for 5 years, I was like, I think it reaches a climax. So like, no, this is the climax. To me, it is enough. I need to get out. And that's what motivated me to start this organization. Now, starting this organization, I grew up poor. I've given you that story. And you look at all these poor people. But then, everybody is looking at solutions that are not working. Then I'm like, I was poor, I was able to get empowered, and I was able to come out of poverty. Why don't you empower the families? The focus will be on the families. People are making wrong decisions. So if the focus is on the family, you bring a very big change. And if you look at the family, that is where people are sick. The family is sick. Typical example of HIV/AIDS. Very many people died. And by the time I came out of medical school, 60 to 70% of the hospital admissions were HIV-related complications. HIV, we have it really at the fingertips because we saw all these complications, people dying. And I've seen the transition of HIV from no hope to 100% hope. Because from this year is when we started universal coverage, antiretroviral drugs, test and treat. And you can see from the time I graduated, I didn't imagine that kind of thing will happen in my lifetime. But now, every person you test positive, you start preparing them for treatment. You can see how things change. So now, our focus, the fact that disease, poverty, and lack of knowledge are integrated. Our focus is you also need integrated solution. And that integrated solution, you can't just sit in Washington, in New York, in Geneva, wherever these headquarters are, and look at them and start prescribing. Actually, we say people prescribe problems. You don't prescribe problems, you diagnose problems. If you prescribe problems, then you prescribe the wrong solutions. That is what is happening to UN, all UN agencies, even USAID. We have been working with the USAID now, this is the 4th year. Because now the disease, our approach is the traditional, I was working in the hospital, I told you, people come. You sit in the hospital and wait for people coming, So to the extent that to a doctor, every person is sick, You say even if you're on the street, you look at every person is sick. Because you sit in your desk, on your desk and say, what's your problem? The moment the person enters, what is your problem? But then, when we started this, it is going out to the community, taking healthcare to people. So we started running mobile clinics. Mobile clinic that has everything, It has the antenatal care, pregnant women have their section, young children screening. If you want to do immunization, you can do dental section, eye, mobile laboratory, everything you take to the community. People now realize that big families are a big problem. It is part of what is keeping them in poverty. They want smaller families. They want family planning methods. And you can't go to the communities and give all this information and tell them to go 100 kilometers to get the service. You have to go with everything. Someone says, 30-year-old has 80 children. That's crazy. Some of them start producing at 15 in rural villages. 30-year-old has 80 children. And when says, I have 8 children, I don't want more. Even the husband says, no, we don't want more children. Then you put the implants there and then. You don't have to tell them to move 100 kilometers. That one doesn't need a PhD to talk. You know? It's common sense. So you see the problem, then you are like, what's wrong? What are people thinking about? These are simple solutions. So you can see it took us a lot of time to convince USAID, because now getting HIV positive was becoming a problem. Because people are like, we have all tested. But there are many people there, HIV positive. So we have to tell USAID, if we go to the communities and start screening people for all these conditions, then you have better chance to test them for HIV. And until when they started saying our results are abnormal. Can you imagine? Because the reality was coming out. Testing people. Because now if you want to test for HIV, now people come. You go to people instead of, if someone is healthy, doesn't know whether they have HIV, then why should they travel to go and test for HIV? But if they come with a toothache, if they come with some other problem, you convince them to test for HIV, because the lab is there, and then you are able to pick those hidden cases. So I think that is our argument with the USAID, and it is now in the 4th year. We hope, because it is a 5-year cycle, but there's always, different calls for proposals. But we hope in the next call, they will also be able to listen to what we say, and then we continue the discussion. But as of now, we know it is the 4th year. When it is the 5th year ends, that is it. But the work we have done has been so popular going out to the community. So now the next challenge is, how do we move forward from there? So because we have been able to penetrate the communities the way we wanted, running very many clinics, going to different parts of the clinics. Then the poverty, we address the poverty issue by empowering people using enterprise development. You give people skills. Now, when you empower them, I told you I grew pineapples. That was empowerment. And nobody gave me a handout. So now we're empowering people, giving different skills. Vocational skill in Uganda, vocational education is defined as education without boundaries. If you're a university graduate, if you have not gone to school, you get a skill. That's why I like putting on these fabrics whenever I travel. These fabrics are made by poor women. But you can see, I think I look smart. You see? So, but then if you see this is a woman who is not educated, even in Uganda, because when we have doctors conference, say, who made for you, who made for you, who made for you? And actually at one time I just had to send money to one of the ladies, said, come over, so to take measurements of about 20 doctors. Yeah? And then pictures of kind of fabrics they chose, and brought over. That is what we need. Empowering people so that they're able to solve their problems. So we are empowering agriculture. Our economy is predominantly agriculture. So you give them different skills of growing vegetables. That is what our people want. They don't need a solution that is prescribed with a problem that is also prescribed. Those are the things we are looking at. And then lack of knowledge, we had started with the drama. Youth acting drama, if it is about family planning, HIV, all these different topics you take out to the communities. But then every time we sit, evaluate, look at the course, then they came up with filming. Because drama, you take people, and then you can't take people all over. But films are very popular in our communities. Local language, people are able to, it is both entertainment and knowledge, education. Now, when you go out to the communities, you say, I want to talk to you about HIV. You make all these announcements, you may be lucky to get 20 people if you are going to give a talk. But if you say you are going to bring a film, you need a football field. Over 2,000 people. Actually, we have screens now that show both sides. You put the screen in the middle, the whole of this side is the whole of the other side. People can be there for 5 hours. So you pump them with as much knowledge as you can, and as they are enjoying whatever is there. You can see that is appropriate solution for local problems. We have to solve. One of the things we are now looking at, how do we improve? These are the youth. You can see they're using very simple, basic technology. Part of this partnership is how can they get more skills? Yeah, it's just now about these youth getting more skills. Our children are watching cartoons made in Africa. So how can we make cartoons in Uganda, in Africa? So that, there's no cartoon where children are taking goats to eat. So we need those kind of cartoons, which brings local. And we have started a program of writing books. And these books are written by our teachers, stories. Because I have a small girl, 8-year-old. I can't even buy books for her, because the books are not there. So now we have started this program. We have partnered with a company that has accepted to subsidize for us. So now our campaign is $1, one child, one book. So these are stories. So it's just like the way film has become popular. We also want books, children to own books, then should be able to write stories that are around issues that need to be addressed. So you bring them in form of stories. They own these books, they can read them over and over. These books eventually will be translated into local languages. But the fact that it has been a hit, the issue now is how do we take it to another level? So these are some of the things we need when we are talking about partnership issues. Because when you are partners, you work about, you sit together and then say what is the challenge and what is the appropriate solution. That is partnership. But then donor relation is they come up and say, we want this, these are the targets, these are the, different conditions. But you just have to learn, even if they have those conditions, but you have to learn to fit your challenges into their conditions so that you coexist. You also need the money, You can't say completely. Of course, some of them, it is not going to have impact. We have, rejected so many donations where, this one is not going to do anything. So you rather be without it other than eventually someone saying, we gave them $1 million, we don't know what they have done. Because you are telling me what to do, and I'm telling you it can't work. So you rather be with your money, then I be with my integrity. So instead of me failing because of your problem, and then you making noise that I've failed, I remain with my integrity. That's why I like the universities. All these crazy ideas, the universities are about crazy ideas. Our partners are the biggest partners are universities. Every year I travel for 12 weeks. This is the 6th week. I was in Canada, different universities. Started with our local institutions. Because we designed this system such that people must learn. And it doesn't have to be formal because there's too much bureaucracy. You go to the university, it can take 10 to 15 years to accept your idea. I work with 5 universities in Uganda. But I told them I don't want their job. We have MOU with the university. You see, they send the students. But every time students go there, Everybody is like, what pill did you give these students? You know, they go changed, they go with a lot of knowledge. I go to these universities, have my own program for teaching. So I don't necessarily focus on what is in the curriculum. I focus on what is real, what the university is not giving. So whatever we are doing is what we call real. So these are some of the rural learning centers. These are not schools. Find some places, a school is like 20 kilometers. Many children can't go. So parents have started rural learning centers. And these are some of the centers where we have started distributing the books. So we hope it is the newest project, but you can see one local company has come to help us because they see this is a genuine, you know. Of course, the owners of these people, of these companies are also local. They're seeing challenges and they're looking at, we are really trying to come up with a solution. So if something is accepted at home, then eventually we get other partners abroad, then we really see it growing. So this is our newest program. We're able to launch it in these community learning centers. These are not schools, under the trees. You know, you see people are trying to do something, but they have completely no resources. So we need a lot of publicity and then see how we can take this to another level. Teachers have come up to volunteer to write stories. It's like, this is what we wanted. This is how we can be useful to the community apart from teaching. So these are some of the different communities we have gone to. This is just now the summary of the work we do. This, nobody sat down to say this organization should look like this. Started as a small HIV clinic. I told you by the time I left medical school and working in the government, HIV was everywhere. And when we started also integrated approach to HIV management, then the number went up, the number of people coming up. So within 2 years, we had over 10,000 people, which other people had failed to do, because we are managing HIV under one roof. Then we started going out to the communities. Going out to the communities, realized there were many other problems, not only HIV. So we kept coming up with all these solutions. One of them is the Rabbit Project, which has been, Rabbit Project, there were two concepts that informed us towards starting this. One, we had a goat project with a partner from Canada. This is the 10th year. We have not reached 100 families because one goat produces twice a year. It takes long, it takes ages. Then second, government with World Bank, they had chicken project. See, that was prescribed. They gave chicken to people, poor people. Chicken, you have to feed them. How can you feed the chicken if you can't feed yourself? So that was a prescribed problem, prescribed solution. It failed. And we are happy that they accepted the defeat for the first time. So now we came up with the Rabbit Project, piloted. Because we know rabbits eat grass. No poor person is going to buy grass. You see? Grass leaves are everywhere. You just go and grab them. You don't need money. You don't need a budget. So we got local species of rabbits, put them in an environment like this, because we had no idea also how to rear rabbits. But we kept learning, reviewing literature, consulting, you know. After 3 years, we got 3 rabbits. Took us a lot of time to get the 3 rabbits. 2 females, 1 male. Then after doing all the studies within a room like this, 3 years later, we had 2,000 rabbits. Then we started giving out these rabbits. Malnutrition, you know, then poor families. Then after 2 years, we tried to do a small pilot survey. Again, after 2 years, there were 2,000 families keeping rabbits. You can see students have written a lot about how the quality of life has changed. Very many people living on less than $1 have come out. getting $5, $6, $7 per day. But now, the challenge is we need the statistics to convince people. You can see these figures are the ones convincing you. Now, this is typically when we go to the communities, we use schools, so you can see very many people come, the lines are very long, but that is what people want, taking services to people. So the only infrastructure that can be able to handle this number of people, schools, so that all these different clinics we are talking, we use classrooms, and then you screen the school children, you give them medicines for worms. Yeah, so these are different aspects. Of course, when students are shadowing, that is now how they participate, move along the different, then talking to the children, deworming them, so fluoride, dental. Then the nutrition center, you can see this is protein deficiency. So this is when the nutrition center was very, very busy, teaching mothers, getting, very, very busy. And then we get very severe cases like this in the communities brought by community members. When you get a severe case like this, it's like this is witchcraft. People just wait for this child to die. But the community members were able to bring, and were able to, many of these children were able to survive. But as we talk now, this place is empty. So when it is empty, that means very, very successful outreach program, talking to people. So that success, we need to build on it. You can see very dirty water like this, but we have sat with partners. Stanford engineering students came up, designed the rainwater harvest system. So it's what we are trying to work on. Our place is hilly. So instead of people going down, now you just, when it rains, this water is stored underground, and then when there's no rain, you use it until when the rain comes again. These are local solutions. So now these are like a very old woman, the children died of HIV/AIDS. Now these are grandchildren, very many. Actually, all these were being followed because they were from nutrition center. Now, this woman cannot dig. He's too old. And these children can't do anything. But all of them can feed the rabbits. So you see, these are the kinds of families we are turning around. And eventually we are looking at 5, 10 years from now, we want to have a very, very robust evaluation of some of these things, and we should be able to embarrass the world that they are doing the wrong thing. So these are local practices. You can see children, a child has diarrhea. These are some of a child has diarrhea. There's a belief that it is the tooth. And then these are traditional healers. They remove the normal tooth. But then it is a belief. And they are doing this because they have no option. If there is an option, then people don't do what they are doing. Now, when we started the outreaches, all these practices have died. Because if someone says the children has problem with the tooth, then when we come, they bring the child. So even when the students come, we take them to see the traditional healers, how they practice. But we are transforming their practice, telling them some of these things don't work. So we have to work together. Then these are typical, very poor, they're traumatized because of poverty, and they have to be counseled. These are people like they have given up. They can't believe they will ever come out of poverty. First have to counsel them. Actually, a person like this, if you give them $10, they can collapse of shock, because they will never imagine they will get $10. So that is the kind of work we are doing. And then we have proactive intervention. You go to rural areas. A woman doesn't go for antenatal, she has 3 babies. Then all of a sudden delivers 3 babies at home. The volunteers come and tell us. And then first you have to take some clothing for warming. Otherwise, they will die very early. Then milk. So a number of interventions. And these they were carrying a pregnant woman to the hospital, bleeding. They walked for 3 hours. They still had another 3 hours to reach the hospital. So these are some of the things that motivated us to start the maternal hospital. So this is a typical interface where we get foreign doctors plus our doctors working together. Because at times, big groups of students come, then we get our doctors, we get our university faculty members plus foreign faculty members, then there's that joint, but deep in the communities. So as students are learning, people are benefiting. You can see all this crowd, but dental, more advanced. Now they have come with the machines to fill, even replace the teeth, give glasses. All these glasses, when you no longer use, they are refurbished, they are taken there, and the religious leaders are very happy with me because everybody is reading Bible and the Quran, because we are giving them glasses. So this is where the students stay and volunteers. I think some of you, when you saw the other house, then you are like, oh my God, how do I stay here? But please keep calm. When you come over, we have something better for you. Running water, electricity, Wi-Fi. Though you may get trouble going to YouTube, but you can text the home. A developing country remains a developing country. Thank you.
We can open it up. We have about 15 minutes if anyone has any questions for Dr. Geoffrey. Anything you'd like to ask? Yep.
I wonder what role you see for VHT's organization. Do you work with VHTs?
Yeah, we work with the VHTs, but then, VHTs was a government. The policy is very good, but then the VHTs are not properly trained. Actually, recently, USAID did the evaluation like VHTs are a mess. So they were, I think, designing a program like community extension workers. But now for us, you can see our nucleus is HIV. There are so many people who have helped out of HIV. They are now living healthy. Actually, they are the first volunteers. They are our VHTs, in other words. So we give them different trainings. But the system is at a village level, you need people to do mobilization, to give education. That is the primary health care. Then when someone has a problem, that's when primary care starts, entry into the care. So when we go to the community, there's both primary health care and primary care, which means there are many sick people who need care. So you provide both. So then you work with because you go right at the village level. Then you interact with the community health workers, they learn more. So, and we are the only ones doing this, going to village level. Because what people typically do is medical missions, medical camps, go once in a while and come back. But then we have a program that runs consistently. That's why we like the partnerships with the universities, because the more we develop whatever you have seen there, the more students are able to learn. Yeah.
What can you talk a little bit about what your funding sources are and funding needs?
Actually, right now, number one, I always tell people, we say, what do you need most? Say we need partners. We need people to hear the story. Now, the fact that all of you have heard the story, what next? Go out and make noise. Because when you make noise, you never know which ear will hear that noise. To me, that is number one. Number two, come and see. The moment you see, you will not come back the same. Your mind will keep, how can I help? The moment the mind changes to how I can help, then you have many connections. You have someone, I can see, you can see $1 is useful to us. And many times I tell people, oh, you don't have to look for rich people. If you have 100,000 people who can donate $1, you see? Or if you have 100,000 people who can donate $10 in American standard, then that is like a whole world to us. You see? So that is our approach. Many people, small donations. And then, these small donations are actually moving the ones moving us. People raise 2,000, 3,000. It is convenient, but it makes a very big change. The whole of this nutrition program, we started with the students from Wayne State University. It was a student program. I will go there every year, they organize dinners. You can see. It just like about $6,000 a year. But there was another program running of $3 million. If you go there and ask, nobody even knows what that program was doing. But for us, we only need $6,000 a year. That is it for nutrition. Those who put 3 million, you say, okay, you do the way you want. We only need 6,000. But they also can't give us that 6,000. You see that? So that is the challenge. It needs understanding, resource, human resource. 90% of our nurses, don't know computers. All of you are computer literate. People always ask me, what is the criteria for coming there? You need medical students? I said, no. You just need to be alive and breathing. That is the criteria. If you look at that model, you can do anything. You have a skill to help anywhere. So that's why we don't block. And multi-sectoral approach. The world is now about multi-sectoral. You need lawyers, you need engineers. Actually, one of our biggest partners in the US, CFHI, Child Family Health International, we have been surprising them. Because I went to Stanford to give a talk. They invited me to give a talk. I said, no. I've given talks, but getting to Stanford is not easy. I said, now that I've come to Stanford, my talks will be unique. So I said, the role of engineer in global health. That was my talk. What is the result? We have designed rainwater harvest system with them. Because I give the concept, I give what people need, then the mathematics and the calculations and computer graphics is theirs. We have designed the motorcycle ambulance. We were looking for 40,000. The smallest quotation was $40,000 for a small ambulance. You have seen where they're carrying this woman. The roads. Now a motorcycle ambulance can go in that road. And a cost of $5,000. And we are looking for that $5,000 to get the first one. For them, people also have principles. There is design, you look for the funding. So they have designed, and we have got local partners who can manufacture. So we only need to get started. So they have designed a community insurance scheme, because that was what we wanted. There are a number of community insurance schemes, but they run on unprogrammed, So, but we have designed a system, computerized, how it can run, everything. You can see that is huge. That is a very, very big consultancy work. If you are to engage consultants, it's hundreds and thousands of dollars. So we have all these needs. One, make noise. For us, we don't need a lot of money. Small amounts bring very, very big changes. And then if there's something you can do, just do it.
We have time for one more question. Is there a question?
I had questions, but you didn't.